So if you step back a few years, I used to work in a tertiary care hospital where everything used to function like clockwork. You come in the morning, see your patient, go to operation theater, take decisions. You never have an idea as to what else happens outside the area of your surgical domain or directly to patient interaction. But then I moved to a tier 2 city, to a private medical college, and that's when the reality struck me. And that's when I realized that just the surgical skills or just taking a decision as to when to operate, which patient to operate, has a major bearing, but it is just a part of the entire system which leads to the final outcome for a patient. And that's when I started getting involved when I started reading about quality and safety, and then got involved with an organization called CAHO, whom I'm representing here. It's Consortium of Accredited Healthcare Organizations. Some of you can look it up. So it's a pioneer organization in India which is actually promoting quality and safety in healthcare in the country. So when we say, when we use these words, quality and safety in healthcare, the first reaction, and I know it is the truth, the first reaction that comes from any doctor, any clinician, is there is a pushback, and it is like it's a waste of time. There are reasons for this. I'm not saying everyone, but there are reasons for this. First and foremost being that throughout our medical training, we've never been it has never been stressed on us about the need for quality and safety in healthcare, and we have been focused mainly on the theoretical aspect, the surgical aspects, and how to treat a patient. But gradually what has happened is a lot of other people have come in. Healthcare started off with just the doctor and the patient ages ago, and slowly now it's a huge system where we are just part of this entire, we are one cog in the wheel, and there are others who are actually telling us what to do, how to practice, what should you be doing. And so this is one reason why, because we haven't been actively involved in this. Now this is slowly changing, like even next month, the National Medical Council has made it mandatory. We are celebrating a patient safety week throughout the country in all medical colleges. There is an entire list of programs. So that is one part of it as to why there is a pushback. The other thing which I feel is that the way things have been implemented with regards to quality and safety, it is not exactly perfect. Most of us now, we feel when we actually go through the entire process, it's a lot of time that's being consumed, a lot of documentation. Whether it actually does it make a difference, we don't know. That's again a reason because the input of clinicians and surgeons and physicians in all this is minimal in this entire quality safety journey. Across the world, if you look over, it is not actually the doctors who are spearheading this. There are people who are actually interested. And so we need to be involved in this. The other point being that we always have this tendency of being in a silo. Like if you look at it practically, a lot of innovation, that everything that has happened in healthcare, let's say for the last few decades, everything has been from other fields, be it the latest drugs, be it the innovations in surgical technology, all this. We have a history, examination, our operative skills, but we have reached a kind of a level at which we can't go beyond. Now, for us to improve further and improve our patients' quality further, what we need is assimilate and take in the best practice from everywhere. Not gradually. You'll see conferences, if you go for quality and safety, they will mention that, there is this directly implement something. Amazon is doing something this way, implement it in hospitals. That doesn't work like that unless we tell people how to go about it. So with this brief outlook, I'm going to talk to you about patient safety and quality in healthcare. Initial part of the talk will be getting you familiarized with some of the jargon, because what happens is when we get flustered when we hear all these terms. And the latter half, the small part, will be what literature is available on quality and safety. So hopefully at the end of it, because if you see journals now, there is always a section on patient safety and quality now. Everywhere, it's coming as a part, so we need to know as to what this actually means. In a simple way, when you say ask people what is quality, then people again get dumbfounded when suddenly this term you are asked to describe quality. If you ask me to make it very simple, quality just means something does the job it's intended to do, does it well, and the final person, the person who's benefiting out of it, is satisfied with that. So when you look at healthcare, it will be that you do a treatment well and the patient is satisfied with the care. Now, core point about quality is always measured. To do anything related to quality, you need to measure it. Without a measurement, you can't do it. And then you apply certain quality tools. The whole structure of quality This is taken from the industrial point of view, but there is a framework called the Donabedian's framework. Anything related to quality is split into three. There is a structure, there is a process, there is an outcome. So structures in healthcare, if you see, what are the number of beds available, what should be the ideal ratio, what is the nurse-patient ratio, how should you be doing this. Processes is how you actually do the entire treatment plan and how the patient is taken care. Outcomes would be what finally happens to the patient. For example, your fusion rates and your other thing, infection. So those are your outcomes. So anything with regards to quality comes in the purview of these three parts of the structure. And when you assure the patient or the government or anybody that, we are looking at all these standards and the outcomes and the key performance indicators, that is what is called quality assurance. So if you look at JCI, NABH, they just have these manuals which have this entire set of standards and guidelines. So then that is what is called quality assurance. Next, an important phrase here is the terms called the continuous quality improvement. This is again a cycle which is called the PDCA or the PDSA cycle. It's called the Plan, Do, Check, Act cycle, popularized by Edward Deming of the famous Toyota fame, who implemented quality there. So when you want to improve something, you make a plan based on the feedback as to what will you like to improve, how will you like to do that. Then perform is actually you implement, is the do part of it. Then you analyze the results. And then after that, finally you act. Act means either you adopt these changes which you have tried to do or you reject them. And then, so this cycle, so this continuous PDCA cycle is what is called a continuous quality improvement cycle. The next common misconception about evidence-based, one of the esteemed speakers was mentioning about the evidence-based cycles, about the levels of evidence we need to take in. Absolutely. Along with that, there is something which we as clinicians don't realize when we just look at journals. When you take the key term as evidence-based medicine, there are two other factors to this which are part of evidence-based medicine. That is not just what is published in journals, and let's say there's level 1, level 2 evidence which you're going to implement in your care. There are two more factors. One is physician judgment. The next is the patient's preference. So when you take evidence-based medicine as a whole, your social, your economic, your geographical, all those factors also come in when you finally implement evidence-based medicine. The next thing, where I commonly see a misconception among clinicians, is about clinical audit. Most of the places, when you ask somebody about an audit, they feel an audit means you just look at the last 100 cases or 1,000 cases, look at the data and publish the results. That is an audit. Actually, a clinical audit is not that. A clinical audit is when you compare your care with the standard of care that is already described. It could be an international guideline, it could be a national guideline, it could be your standard of care that you follow that's been there in your geographical region or in your hospital. You compare what you are doing along with that standard of care, and then see the deviation in this. Do a root cause analysis and why this deviation is happening, and try to improve so that you get up to the standard of care. So that is how a clinical audit is a quality improvement process. Now, this is another new term which is coming in a big way. It's called systems thinking. And this is something, again, all of us need to know, because gone are the days where everything was supposed to be quite put down on paper, point-wise, that this is the standard of care, you do this, the quality will improve. No. If you look at healthcare is one of the most complex and unpredictable systems in this entire world. That's why nobody has been able, you have every kind of organization or a company which is cracking everyone, but if you look at healthcare, no big company has been able to crack it. So a system is something which is an interaction between the people, the processes, the physical environment that is there, all the infrastructure, the technology that is involved, the interfaces. This whole thing makes a system. And for every external force, the way the system reacts depends on how robust the system is. So it is not just the clinician, but it's the entire system which actually makes for the patient outcome. So this complexity of the system is another thing which we need to keep. So everything is now about system engineering and further so and so. So that's briefly about quality. Certain important things about patient safety. All of us clearly know, it's been told to us a million times, do no harm. That is the first dictum. And the entire thing about patient safety, if you look at these, there are these scary reports which keep getting published that medical errors lead to about, there's the third most commonest cause of death for patients in hospitals. Now that is actually, there are many rebuttals for that this actually doesn't hold true, but still, we all do realize that medical errors do happen. So the JCI, that is from America, and the WHO, they had a list of common focus areas about improving patient safety generally, and this included identifying patients correctly by their actual hospital number or UIN number, improve effective communication. This is about critical information or about handovers, specifically verbal communication, high alert medication safety. Things which are high alert medications are drugs with very narrow therapeutic index, drugs like narcotics, look-alike or sound-alike drugs. Safe surgery, this is again which directly impacts us, operate on the correct patient, the correct site, and the correct site. Reducing the hospital-acquired infections, central line associated infections, CAUTIs, surgical site infections, and so forth. Fall prevention, again, a major part in orthopedics. So all this now has been encompassed in a single umbrella. This is what is now coming to the journey forward, is something called clinical governance. This has again been instituted by the NHS in UK. And all this, what we have discussed about quality and safety, all these now is to, so achieve, it's all about achieving excellence in clinical care, quality of care. So that's clinical governance. So now let's come to briefly, I think I'll just finish quickly about pediatric trauma. Certainly I was just looking at literature that is available and some of the journals that will be published. And so I just highlighted some of the articles that are there. So the first few, what I'm going to highlight, shows the complexity of management of a trauma patient. So this was an article, this was published from Johns Hopkins. They showed that they looked at around 2,000 patients and looked at how the patient went through, right from the arrival to the ED, ICUs, ward, all those regions. And they actually found 28 different kinds of patient pathways by the time the patient actually got discharged or the patient died. And 20 care transition from area to area. So this shows how complex this is. This was from the Wisconsin group. There they looked at the pediatric trauma patients, and again a big number. They've identified 53 different kinds of healthcare workers who were involved in treating a pediatric trauma patient. So when you look at this, you understand how complex the system is, the number of pathways, the number of people who are involved. Next, this again was from the Wisconsin group. They identified the various dimensions about improving quality and safety. So here they identified about anticipation, that is actually getting a know-how about when the patient is going to come, early knowledge about the patient, early decision-making, quick decision-making in the ED, interaction with the family, the physical environment that is present, ambiguity about roles. Again, teamwork and ambiguity about roles is another major part in this. The staffing and the resource crunch, cognition of the team, technology, and the type of patient. So if it's a very sick patient, again, this becomes quite difficult. So then some kind of a literature review about some review articles. This was from the University of Washington, where this was in 2012, where they interviewed people, and they also looked at the literature review and found out that the best way to improve care is to have specialized pediatric trauma centers, have a clear-cut guidelines-based management of pediatric trauma, establishment of trauma registries where there is actual data available which can be improved, and also look at quality metrics. For example, they had mentioned this was early fixation of femur fractures. Now, this is where, again, like in the US, I believe there are metrics for rating orthopedic hospitals, pediatric orthopedic settings high, depending on the timing of surgery. And so there was a recent article, I think 2020, from the Mayo Clinic, which showed that this 18-hour thing for femur fracture doesn't actually make much of a clinical outcome difference. So this is where clinicians come in, and rather than people telling us what to do, we should be at the forefront of determining what is the quality of care. This was another...
Pratheesh, could you conclude?
So about this, if you look at it, I'll just conclude. The bare minimum is about, there are various recommendations from various organizations which have looked at pediatric trauma. So it is about having a dedicated pediatric trauma setup. These are the ones which are actually having proper guidelines and actually looking at systems thinking. So this is... So using these processes and the basic quality improvement framework and also getting systems thinking into play, there is a big potential for us to improve, not just the surgical part, and this is my take-home message. Thank you.